Good day to everyone. Let me first thank the organizing committee of the Pakistan Society of Pathophysiology and Professor Yasir Zaidi for this kind invite. I was given a task to give a talk on hepatic encephalopathy. I have nothing to disclose. These are the issues I'd like to address. To define hepatic encephalopathy, the classification of hepatic encephalopathy based on axis, the pathophysiology of hepatic encephalopathy, and the treatment options related to such disease. Let us first define hepatic encephalopathy. Hepatic encephalopathy is a marker of liver failure, which affects about 40% of patients with liver cirrhosis. It is defined as a multifactorial neuropsychiatric or disorder presenting with a broad spectrum of cognitive impairment and neuromuscular dysfunction, largely due to liver's insufficiency or portosystemic shunting. This has been the significant contributory to repeated hospitalizations for patients with liver cirrhosis and has a severe impact on the quality of life. And definitely the presence of hepatic encephalopathy is a marker of poor prognosis in cirrhotic patients with a relative rates of survival of only 36% at 1 year from its first time of presentation. How do you classify patients with hepatic encephalopathy? It is actually classified into 4 axes: the type, the grade, the time course, and the presence of precipitating factor. When you talk of type, you are either talking of acute liver failure, portosystemic bypass or shunt without cirrhosis, and cirrhosis. When you talk of grade, it's the presence of a covert or overt time course related to episodic, recurrent, and persistent, and lastly, the presence of precipitating factor, whether they are precipitated or spontaneous. Let us first take the classification of hepatic encephalopathy according to grades. So you actually classify them as either unimpaired, covert, and overt, depending on the mental status, the performance on specialized tests, and the presence and absence of asterisks. This is in pattern with the West Haven criteria for hepatic encephalopathy and symptoms on the right side of your screen. Therefore, if you correlate either the 3 factors on the left side, you are now able to identify whether your patient has either impaired, unimpaired, covert, or overt hepatic encephalopathy. In patients classified according to the time course, it is either recurrent, episodic, or persistent. When you talk of recurrent, this is more than 1 distinct episode within 6 months. Episodic on the right side of your screen when it goes down to normal, and 1 episode in 6 months, and persistent when your patient has always had hepatic encephalopathy and never goes down to normal. So it's always clinically detection above the clinical detection level, and persistently patients never recovers from hepatic encephalopathy. So when you correlate the 4 axes, you have type, grade, time course, and presence of specific factors relating to the hepatic encephalopathy. This is then the overall classification when you produce a patient or when you actually look into a patient to see whether your patient's and what treatment options your patient needs. There are different psychometric tests which are necessary, and I'd like to only hype on the role of psychometric tests in the evaluation of the minimal hepatic encephalopathy. So in the absence of physical examination findings of hepatic encephalopathy, this neuropsychiatric or psychometric tests may be used to identify disturbances in attention, visual spatial abilities, the fine motor skills, and the memory. So let's take first the first, which is the psychometric hepatic encephalopathy, which utilizes 5 tests. And these are the number connection test A and B, the digit symbol test, the serial dotting test, and the line tracing test. This test primarily evaluates attention, visual spatial perception, visual spatial construction, and psychomotor speed and motor accuracy. The next test is the Stroop test. The Stroop test evaluates the selective attention and process speed by the interference between visual color and a written color name. So the Stroop test is actually a smartphone app. So you can see how technology now plays a role in identifying patients in minimal hepatic encephalopathy. So it is a screening tool for minimal hepatic encephalopathy by assessing selective attention and inhibitory response. And this test utilizes an off state that has neutral stimuli and an on state that has incongruent stimuli. The critical flicker frequency test, on the other hand, utilizes a sort of a specialized equipment. So the CFF test is used to assess the visual discrimination and functional efficiency of the cerebral cortex. It is used by performing a luminous diode to generate intrafoveal stimulation and thereby assess the person's ability to detect light flickering. This is a sensitive and reproducible means to quantify the severity of hepatic encephalopathy. So as I mentioned, it utilizes a specialized equipment and is not valid for persons with red or green color blindness. The continuous reaction test, or the CRT, measures the ability of the motor reaction and requires specific software and specific strategy to identify patients with such. It is quite harder to administer as compared to the others. The scan test measures the speed and accuracy of digital recognition and memory exam in a computerized format. So if you largely and clearly, the psychometric test uses technologies, uses smartphones, apps, short of the time and tested PHES or psychometric test number connection test. So it actually has a more valid way of identifying patients early on. As you know, in minimal hepatic encephalopathy, it waxes and wanes, and therefore it changes through time. And therefore it's always important to be able to test these patients early on, because this has an impact in the quality of life. So let's now talk of pathophysiology. The key substrates implicated are actually ammonia and glutamine. Several studies have demonstrated that cirrhotic patients who had or are experiencing significant neuropsychiatric symptoms had elevated blood ammonia concentrations. However, the levels were not predictive or consistent with the severity of hepatic encephalopathy. Glutamine, which is a key amino acid that plays an important signaling role for processes including gene expression, cytokine production, and cell proliferation. Enhanced activity of glutamine is primarily noted in the skeletal muscle, brain, heart, and hepatocyte. Glutamine is metabolized in the gut and kidney to ammonia and glutamate. Ammonia is then detoxified in the kidneys and the liver and is excreted as urea. So what happens in liver failure is that ammonia escapes the urea cycle and is detoxified to glutamine in various tissues. Then a vicious cycle is formed whereby increased ammonia concentration due to the impaired detoxification in the liver further activates glutamine synthesis, leading to glutamine catabolism, and this results in hyperammonemia. Now, what is evident is that the enhanced activity of glutamine has been shown to exert adverse effects such as swelling of astrocytes, increasing catabolism of branched-chain amino acids in skeletal muscles. So when you look at it closely, it is actually the presence of altered gut microbiota producing a pro-inflammatory state. This also increases the production of ammonia, as well as the inflammation produces more pro-inflammatory cytokines, leading up now to a process that leads to hepatic encephalopathy. And of course, as mentioned, the time and tested strategy of altered urea cycle plays a role in patients with hyperammonemia and clearly a role in hepatic encephalopathy. So treatment options for hepatic encephalopathy are largely geared to decreasing the ammonia levels. So here you can see that in patients with possible overt hepatic encephalopathy, you first confirm it with the test that I have mentioned. It is largely important to determine the other causes of altered mental status, and if there is a precipitating cause, treat the precipitating cause. If you're not able to treat the precipitating cause, start empirical treatment to attain improvement of mental status, and probably consider secondary state. But it is mandatory, and if you are quite lucky to identify a precipitating cause, treat the precipitating cause, because this could actually decrease the progression of liver cirrhosis. As I mentioned, ammonia is produced and is clearly in the center of the problem, and it is produced from the nitrogenous products by bacterial catabolism of urea, because you have an altered urea synthesis, proteins in the gut because you have alterations of your gut microbiota, and from the amination of glutamine in the small intestine. So all of these factors play significant role in patients to produce hyperammonemia. And with this, as a result of the liver dysfunction and portosystemic shunting, ammonia then cannot be cleared adequately. So this increased ammonia state in the plasma increases the metabolism of glutamine via the glutamine synthetase, and this leads now to intracellular swelling of the astrocyte. For me, this is the best physiology that hallmarks ammonia. So I have labeled the pathophysiology of ammonia using the yellow form for ammonia, and of course, the role of pro-inflammatory cytokines using the circles that are clearly related. So when you look at it closely, hepatic encephalopathy physiopathology of ammonia and inflammation. So the yellow marks are the ammonia, the encircle marks are those related to a pro-inflammatory state or an inflamed state. And these are the main actors now of patients with hepatic encephalopathy. So as opposed to previous theory, the main source of ammonia in the portal circulation is intestinal glutamine. So once increase in the portal circulation, ammonia increases in the systemic circulation as a result of liver failure. And this is due, as I mentioned, to the reduced activity of the urea cycle and or portosystemic shunting. So in the case of liver failure, ammonia detoxification into glutamine through glutamine synthetase is only possible to the muscles, cells, and the astrocytes. So in the muscle cells, this reaction requires branched-chain amino acids, which are decreased in patients with cirrhosis. In the astrocytes, the rapid increase in glutamine explains the occurrence of cytotoxic edema seen in astrocytes through its osmotic potential. So in more aggressive diseases, the osmotic components, myoinositol and taurine, are excreted outside the cytoplasm, and this then leads to a problem related to glutamine in the astrocytes. The rapid increase in glutamine then produces a glutamine cytotoxic edema seen in astrocytes, as I mentioned, because of its osmotic potentials. And these more progressive diseases The osmotic components, the myoinositol and taurine, are excreted outside the hepatocytes or outside the cytoplasm to counterbalance the glutamine increase to try and prevent astrocytic edema. And then the observed neuronal effects may vary. Hyperstimulation and seizures may occur due to the accumulation of glutamate in the synaptic cleft, and coma due to the increased GABA in the brain. So the psychomotor disturbance and due to the other neurotransmitters. As a result also, as I mentioned, aside from hyperammonemia, you have here the pro-inflammatory cytokine release. So this then, because of this, as a result of the modification of the gut microbiota, an intestinal barrier function is altered and bacterial translocation abnormally then increased. So this depression to the liver disease favors pro-inflammatory cytokine production. The systemic inflammation induces an alteration of the blood-brain barrier, and this then produces increased permeability of the blood-brain barrier to this pro-inflammatory cytokines, especially interleukin-1 beta and interleukin-6, which then activates the astrocytes and microglial cells. And these steps can be worsened by the hyperammonemic state of a patient. And of course, there are also other substances that play a role, such as the aromatic amino acid, because you have depletion of your branched chain amino acid. You have increased GABA tone through the benzodiazepines like components or neurosteroids. And even when you give so much drug on a patient with cirrhosis, there are also drug implications of accumulation of these drugs in the CSF fluid, which now contributes to the pathology in patients with hepatics and sepsis. So clearly what is stated here is that aside from the ammonia levels that are increased, there is also an increase in the pro-inflammatory cytokines evident by this pathophysiology, and therefore treatment largely is used to identify these specific hallmarks that I have mentioned. So I have labeled to you the different strategies of treatment options for hepatic encephalopathy. The NAD, which is the non-absorbable disaccharides, antibiotics, I will highlight on rifaximin, ammonia nitrogen scavengers, the albumin dialysis or MARS, probiotics. I will give you a small talk on that. Fecal microbiota transplantation still on the rise. BCAA still on the rise. Zinc, I think this is something that has something to do with the urea synthesis. So let us first talk of the NAD, the non-absorbable disaccharides. This is a pre and non-absorbable prebiotic and non-absorbable disaccharides. It has been widely used in clinical practice, recommended by all guidelines as the first-line treatment for episodes of hepatic encephalopathy. Treatment should be continued as you have resolution of symptoms to prevent further episodes. And in the colon, as I showed on the left side of your screen, lactulose is converted to lactic and acetic acid, thus reducing the pH, intraluminal pH, promoting the utilization of ammonia in the gut bacteria. So there is already a meta-analysis of 38 randomized clinical trials, which shows that when compared to placebo or no intervention, the non-absorbable disaccharides is associated with beneficial effects, in addition to reduction in serious adverse effects with liver diseases, including liver failure, hepatorenal syndrome, and variceal bleeding. So you can see here a study that was published in 2016 and a meta-analysis showing a decrease in primary endpoints of mortality in patients with cirrhosis, patients with minimal hepatic encephalopathy, as well as prevention on mortality in patients with cirrhosis, both an overall strategy, random effects of both showing that this clearly has its effect as far as reduction of mortality. Other treatment options has been into play, the LOLA, which stimulates enzyme activity, leading to increased urease excretion. We have ammonia scavengers, and they lower hyperammonemic state, as this is clearly the center of everything, by providing an alternate pathway to urea for waste nitrogen excretion in the form of phenylacetylglutamine, which is excreted in the urine. I will highlight on rifaximin. Rifaximin is a synthetic antibiotic related to rifamycin, and it has a wide spectrum of bacterial activity against gram-negative and gram-positive bacteria, both aerobic and anaerobic, a very low rate of systemic absorption, and utilizes an antimicrobial resistance because it's non-absorbable systemically and small intestines, and therefore it is safe. I think one of the things is it's safe, and clearly it shows on the right side of your screen whether your primary endpoint is a first breakthrough in hepatic encephalopathy or your secondary endpoint, which is hospitalization. You have clearly shown that a treatment of patients with rifaximin has improved both primary and clinical endpoint. Let me hype on the gut microbiota. On the left side of your screen, there is a healthy microbiota which is maintained in the gut lumen. And what happens when you have environmental factors or innate immune system problems, you now have an alteration or translocation of gut because of the leaky gut, and this then goes to the portal circulation, activating the pathogen, the PAMPs and the DAMPs. This then increases the activation of the pro-inflammatory pathways, the anti-apoptotic pathways, and the antiviral pathways. And this then leads now to a problem that is related to liver diseases. And you have said that the mounting evidence, even that alcohol alone increases the gut permeability and liver exposure to the different endotoxins. And this activates the toll-like receptors and the NOD-like receptors, producing now a problem that is related to liver failure in patients with alcohol, in a subset of patients with alcohol-induced liver disease. So several studies have shown that the mouse that suggest that endotoxins promotes liver disease because they drive the copper cell activation. And this liver injury can be prevented by antibiotic treatment, by eliminating copper cells, or by neutralizing the TNF-alpha. So clearly what is evident is the gut microbiota is associated with diseases, and it is essentially largely due to the gut microbial products activating the toll-like receptors and the NOD-like receptors of the innate immune system. So in patients with hepatic encephalopathy, you can see here that they have tried to use probiotics. Mechanisms of actions are largely on the right side because this can decrease PAMs, then decrease problems of activation of the pro-inflammatory state. And it has been said that probiotics in a certain point can reduce portal hyperammonemia, decreases the bacterial urease activity, ammonia absorption, intestinal permeability, and largely is then related to nutritional status. And this has been published about 6 or 7 years ago, showing that probiotics may have its effect in reduction of inflammation and oxidative stress and neurotoxin absorption. So in other words, when you talk of the pathogenesis of hepatic enceph, doesn't only talk of hyperammonemia, it talks of gut microbiota and dysbiosis and small intestinal bacteria overgrowth. Now this SIBO, or the small intestinal bacterial overgrowth, has gained so much interest because of, it has been said that it is a consequence, because of the SIBO, it has reduced gut motility, reduced gastric acid secretion, luminal IgA deficiency, and malnutrition. And this results in an impaired intestinal barrier integrity and therefore increasing bacterial translocation through the release of ammonia and the endotoxins in the circulation. So clearly what is evident is that there are different dominant species in cirrhotic patients. You can see here that the studies on the left side of your screen have identified the microbiota changes in hepatic encephalopathy, and this is where now the large interest of research because you have a collapsed gut, liver, brain in hepatic encephalopathy, and therefore the initial factor of gut microbiota dysbiosis can be possibly a relevant change in the intestinal barrier and portal system. So this then produces an altered intestinal permeability, bacterial translocation, systemic and local inflammation, and then the modified microbiota composition with reduction in commensal bacteria and their metabolites, such as the short-chain fatty acids or the excessive amino acids of gamma-aminobutyric acid. So therefore, you have an abnormal status, which finally affects the liver, and of course, in essence, also the ammonia metabolism. Lastly, I'd like to hype on nutrition in hepatic encephalopathy. You can see that following the production from the diet by the gut bacteria, urea is catabolized to ammonia. So normally it is actually the liver who detoxifies the nitrogen. But in the context of cirrhosis, liver metabolism of ammonia is actually impaired. So this, I have already stated that. And you can see that when you cannot remove ammonia, it uses other organs, the muscles is uses it, and this inter-organ trafficking strategy uses the burden of the muscle. And most of patients with cirrhosis, you have problems that are actually malnourished, and therefore the recommendation has been that you maintain the normal protein level of 1.2 to 1.5 grams per kilogram body weight. So this is the recommended protein level. You don't really reduce it in patients with hepatic encephalopathy because ammonia detoxification uses the muscles short of the liver not doing its function because of the state it has. So the issue settled in 2021, ammonia remains the center to pathophysiology of hyperammonemia, and various precipitants should be identified because they can affect ammonia production, excretion, and neurotoxicity. New mechanisms have been in place related to inflammation in gut microbiota. And therefore now the modification of intestinal microbiota is emerging as a major factor associated with hepatic encephalopathy. And therefore, I'd like to end this with saying that a lot of research are happening on fecal transplantation that has been proposed as a therapeutic strategy for hepatic encephalopathy. So with this, I'd like to again to thank the Pakistan Society of Pathology for this kind invite. I look forward to being there physically. Please keep safe, and I hope you can visit my country soon. Thank you for your time.